backgrounds at the CUNY School of Public Health. I'm Dennis Nash, professor of epidemiology here in the Department of Epidemiology and Biostatistics, and also I'm executive director of CUNY's Institute for Implementation Science and Population Health. And when our dean asked me to identify a speaker from on behalf of our new institute of Implementation Science and Population Health, I immediately thought of Donna Spiegelman. Donna is a speaker from on behalf of our epidemiology at Biostatistics at the Harvard School of Public Health, and we of course wanted her because she's a methodologist who's thinking a lot about the field of implementation science. And
muted.
As you may know, she recently received the NIH Director's Pioneer Award specifically for the purpose of advancing methods in implementation science, which of course is something at the heart of what we're trying to do here in our new institute. So I do want to read a little bit from the announcement of this Pioneers Award that Professor Spiegelman received. She was one of 10 researchers honored by the Institute's National Institute of Health director, and she is believed to be the first epidemiologist and biostatistician and the first faculty member from the School of Public Health at Harvard to receive the award. The 5-year, $500,000 prize recognizes individual scientists of exceptional creativity who propose pioneering and possibly transforming approaches to major challenges in biomedical and behavioral research. Professor Spiegelman is using this opportunity to focus on the development of new methods needed to advance the field of implementation science. And her area of research is seeking to establish through rigorous quantitative methods which public health interventions directed at achieving the same goal are most effective in the real world. So it is in that vein that Professor Spiegelman came to CUNY today and spent much of it with us in our institute and speaking with investigators, which was great. We've identified several common interests and areas of overlap, which we will continue to talk about going forward. And now I'm happy to turn the mic over to her. She'll be talking to us about toward a unified methodology of study design and statistical analysis for causal inference and implementation science. Donna, welcome to CUNY.
So thank you so much, Dennis, for inviting me here. It's a pleasure to be here. My parents are born and raised Brooklynites, and I myself lived in Brooklyn until I was 5 years old. So it's always a little bit of a homecoming to come back to New York to give a talk and interact with colleagues here. That was a great introduction, and it was a pleasure meeting many of you and reconnecting with one old friend, Levi, who I worked with previously at Harvard. In this talk, I'm going to give some background on what we mean by implementation science. It's sort of a new term, and it has relationships to a lot of other terms that have been heard. Am I being picked up well enough by the mic? Everybody in the back can hear me? Okay, good. This one, you mean? This one's not on, but this one's on, the one that's over here. Oh, I see, I can pick up this one, no?
There's a button to push.
This one picks up you, this one goes on.
Is it good enough though? Yeah. Okay, well, I'm fine, so we don't need to fiddle with the mics anymore. So I'll talk about what implementation science is, and then I'll give some background on methods that are considered part of the general area of implementation science. I'm going to talk about a little bit about a question that Dennis and I spoke of earlier about the rigor of implementation science and what are some of the issues with that and how might we address that. And then I will give, to the extent that I have time, I'll give somewhat of an overview of some of the work that we've been doing in our group that's been supported by the Pioneer Award in terms of new methodologic developments for implementation science. And from my perspective, I'd be very happy for people to raise their hand and ask questions or make comments throughout the talk. We'll also, we're hoping to have 15 minutes at the end to do that. So I hope that there'll be a little bit of a dialogue here as well. So some of the motivation for implementation science in related areas has to do with the gap between research and practice. And this cartoon, I think, illustrates it well. We have a huge body of literature on all sorts of things, but in fact, there's quite a big discrepancy between publication and actually implementation. So this gives, we talk about the cascade in HIV. Well, here's the cascade in so what about laser pointer? No, I guess not. So, and I can't, can I use a cursor or anything like on here? No, I can't. I can use a keyboard. All right. Oh, I see. So here it is. Do you guys see that? Okay, good. So we can see how we go from doing the research to getting it published. And in fact, there's even a gap between publishing research. So I know that I was at NHLBI. I met with Mike Lauer, who's the director there. And he had, when he came in, he did a review of all of the studies that they had been funded and what percentage of those actually had publications. And I don't remember the exact number. I mean, here it's sort of saying that the number might be something like 46% actually see the light of day in publications, and maybe that was around the number. He was not happy about it, that they had invested so much money in all of these studies, but both randomized trials as well as observational, all kinds of studies, and things weren't getting published. And on top of that, he mentioned to me there were repeat offenders, that people who could go back and get new grants after they hadn't published the results of their previous study. So I think maybe there's more attention to this issue now at NIH, and it's harder to do. So that's one way to remedy the gap between actually getting funded and doing all or part of the research and then getting it published. So you submit it, then it has to be accepted, then it gets published, then it appears in bibliographic databases, then it might appear in reviews, and then here we talk about implementation. And this particular, this is not my slide, it comes from a paper by Bayliss and Moran from 2000. They estimated about a 9-year gap between when the research is actually done and when it's implemented. And if you notice, there's no percentages. I don't even think necessarily it's well known what percent of research findings get translated into actual practice. But for those of us, and for me, what inspired me to take a turn in my own career in applying for the Pioneer Award that Dennis mentioned and turning my attention to methods for implementation science, is that I felt like I really wanted in this, say, second half or whatever fraction it is of my career to be doing things that would actually make a difference. Sandro Galea, who was formerly chair of EPI at Columbia and is now dean at School of Public Health, he's coined the term consequential epidemiology. And it's all part of this general feeling that quite a few of us have of like not stopping here at publication, but also trying to get all the way to implementation and trying to have our the products of our work actually make a difference in terms of improving public health, either domestically or globally. Okay. So some of you might have seen this. This is NIH's theoretical overview of translational research, implementation science, and related disciplines. This came out quite a while ago, maybe 8 to 10 years ago, and it starts with T0, which is basic kind of lab science, and then it goes to T1, which is discovery and foundational research. It could be epidemiologic research might fit into the T1, this T1 spoke, and then it goes to T2, which would be efficacy research, where some results might be translated to a individually, a highly resourced, individually randomized clinical trial where to assess the benefit of a possible intervention that was suggested from T0 and T1 research into some kind of efficacious intervention or treatment. And then should that be the case, it might move into T3, which would be the effectiveness side, and then T4, which might be surveillance afterwards. And we might say that implementation science probably fits in the T3, T4 spokes. although not necessarily cleanly and clearly. And then something else that could be of interest, that there may be some information on this. I don't know what it is, but it would be interesting to say. I mean, these look like 5 equal spokes, but if you took the NIH budget and classified grant funding into these different spokes, I think we'd find that it's very heavily weighted to the T0, T1, and even T2 spokes, and much less on the T3 and T4. And where a connection between that gap and maybe some of the methodologic work is that there may be some perception that the research done at this T3 and T4 level isn't as rigorous or isn't real science or scientific enough and so forth. And so coming up with methodologies that people can use, that people can understand, that make the T3 and T4 spokes of the research more rigorous could be helpful in that regard. So in terms of definitions, the first one that I might want to talk about is implementation science. Here I am at the Institute for Implementation Science at CUNY. So there are 3 definitions that I found. This bottom one I feel I personally like the best. Implementation science is about determining what works in real-life, full-scale settings. So it's definitely about translation of findings. It's about public health. It's large scale. It's practical. This white one, I'd say, is maybe the kind of NCI type definition, a systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. And what's different about these two is that this second definition is conditional on having identified effective interventions at scale, and it's focusing much exclusively, in a sense, in getting them out. Whereas this third definition includes the notion of effectiveness, at least in practical large-scale settings. And then this one here is a very broad definition, and I think includes more of the clinical aspects of what implementation science might be, as opposed to or in addition to the public health. So anyway, I think maybe Dennis and your institute probably falls more on the lines of either this definition or that one rather than this one, as I do as well. And if it would be interesting to discuss that further at some point, maybe in the discussion. There's some other terms that are around that seem very closely related to implementation science. So one is operations research. Now that one seems to have gone out of favor somewhat now, but it was much more popular maybe 5 to 10 years ago. And it has to do with the assessment of the effects of interventions on the processes, which have been shown to influence health outcomes. So in implementation science, it's not something we learn in epidemiology, but there are sort of 2 kinds of outcomes. One are process outcomes, which is that you have an intervention to change the behavior of providers, health systems, or consumers/patients. And the goal is to assess whether that behavioral change happened. And then the health outcomes are, do these interventions have an impact on health? Now, some people in implementation science feel like we don't have to look at the health outcomes because we know if people change these behaviors, the health impacts will follow. And so implementation science should focus only on these process outcomes. I don't agree, but it's not a small number of people in this small field who I think feel this way. And I certainly think maybe as a compromise, implementation science studies should probably look at both process outcomes and health outcomes. But you certainly can get funded only looking at process outcomes, given that the intervention, there's a sufficient amount of literature showing that the intervention is effective. Now, another term, this comes up more in global health, and it also derives from the health economics world, is this term impact evaluation. So here, when I look that up, I say assesses the causal effect of a particular intervention, such as a project, program, or policy, both the intended ones as well as the unintended ones. And it's structured to answer the question, how would outcomes such as participants' well-beings have changed if the intervention had not been undertaken? So what's sort of different about the impact evaluation approach is it has this causal inference underpinning. So when they say, how would the well-being have changed if the intervention had not been undertaken, that's when they're talking, very formally about the counterfactual, where the goal of the causal inference, as I was discussing earlier with one of our colleagues here, is what would have happened if we had the intervention, what would have happened if we didn't have the intervention. And the goal of the causal, that's to estimate the causal effect, is the difference between those two, which of course is impossible to view in real life. And so study designs try to optimize getting us as close to that making that counterfactual causal comparison as we possibly can. And in the impact evaluation world, like if you were to apply for a grant at 3IE, you would have to frame your specific aims in terms of these counterfactual contrasts. But in the end, from a practical point of view, and I'm sure you can see I'm a practical person, what you do is pretty much the same as what we would always do when in a well-designed study to evaluate the effectiveness of an intervention. And then with impact evaluation, they focus exclusively on the health outcomes rather than the process outcomes. So there's yet another term, comparative effectiveness research. So some of you might know there's a whole institute called PCORI, and its focus is on comparative effectiveness research. But when you look up the definition of comparative effectiveness research, to some extent it's what we might call in epidemiology focused on what we might call tertiary prevention, meaning comparing alternative clinical interventions to sort of mitigate adverse effects of diseases and in a medical setting, but using sort of rigorous causal inference methods, often in observational type contexts and in real life settings. But the definition of the Institute of Medicine not only considers what I just described, which is how in most universities, when people are doing comparative effectiveness research, they're doing pretty much what I just said, having to do with looking at alternative treatments and large databases in real life healthcare settings. But they expand it to just about everything, including prevention, policy, and so forth. And so the lines between these different so-called disciplines or lines of inquiry, I feel, are quite blurred. Here's an article from JAMA from, what was this from? 2010, not that long ago, where the NIH director is explicitly making a commitment to comparative effectiveness research, which by this more limited definition might not be the greatest news for us who are committed to population and public health, but in the broader definition that the Institute of Medicine gave, all of the work that we do in public health, as well as people doing clinical epidemiology and clinical research, it all fits under the comparative effectiveness rubric. And so when considering certain funders, you might want to frame your work within that type of a sort of line of inquiry. So in trying to figure this all out, I kind of came up with this sort of a diagram of how I saw these different types of lines of research, and starting with even translation. So I showed the wheel. So the translation of science immediately forks in two ways. And I would say forks, one would be implementation science, the other would be the bench to bedside model. And that has to do with taking findings from laboratory research and other sort of science, hardcore basic science lines of research, trying to translate that mostly into drug development and then to patient care. And that's what they tend to mean by bench to bedside. And that's very much considered translational research. The other side, implementation science, the side that I've been talking about up to this point and that I'll be talking about for the rest of the talk, is more of the kinds of things that that we're considering here. So we have monitoring and evaluation. So it's, let's say, required by PEPFAR and many other funders in rolling out large-scale public health programs, whether there's any intention to do research or not, there's a requirement to both monitor process outcomes as well as health outcomes as the program is going along, and then evaluate it at the end. Well, in fact, I feel that monitoring and evaluation with a bit more rigor on various levels, both in terms of data quality and methods, can very much blend into some of these other areas we're talking about. Then another piece that I hadn't mentioned yet is qualitative research and mixed methods. I've come to believe, without any training whatsoever in these areas, because they're not part of the traditional curriculum in epidemiology and biostatistics, is that qualitative research is essential in implementation science. Because when we're wanting to figure out what works or what isn't working, we can collect quantitative data to some extent, but some of this has to be obtained by talking to people, whether it's key informant interviews, focus groups. There's a whole range of qualitative methods that I'm just learning about now that I think are extremely useful. And then I've done some reading on mixed methods so that there can be different sequences. Mixed methods can be done where first you do qualitative research, which could be part of formative research, as I was discussing earlier with a colleague here. And then based on the qualitative research, an intervention is designed and then studied, or there could be qualitative research, design the intervention, then more qualitative research while the intervention is happening to understand. At the end, you might understand, well, what worked and what didn't work, or many public health evaluations fail in the sense that we fail to detect a difference between standard of care and the new intervention that we were very interested in. And we're always shocked about this and very disappointed. But what happened during the course of that intervention? Was it that people weren't taking up the intervention? They were just taking their pills and throwing them in the garbage when they got home? Were the providers not actually complying with the protocols? Was there stigma being initiated that was unanticipated? There's no way we can learn these things without doing the qualitative research along the way. And then after the health outcomes are evaluated, there could be further qualitative research to find out how everybody felt about the whole thing, the providers, the patients, and so forth. So we talked about operations research. That would be looking at these process outcomes, the impact of the intervention on changing processes. Then there's the impact evaluation, comparative effectiveness research, which has to do with the health endpoint. And then another big area in implementation science that I feel like really deepens and enriches the sort of toolkit that I learned as an epidemiologist and biostatistician. First, there's the qualitative part, and then there's the economic evaluation, which is another thing we don't learn. Has to do with cost effectiveness research. And so it's not just what the health impact was of the evaluation of the intervention, but it's also what was its cost and how do those costs compare to standard of care, or oftentimes in projects that I've worked on, you're comparing two alternative interventions that are in equipoise. We don't know which one has a bigger health impact, but we also don't know what the comparative costs are of the interventions. And then finally, another area that was somewhat new to me is the modeling area. So that's very big in the HIV world, is once you get some results from some sort of public health intervention, then stochastic, various sorts of probabilistic models are used to predict, let's say, what would be the impact in terms of cost, in terms of, say, lowering HIV prevalence, in terms of, say, reducing maternal mortality, going out into time, 5, 10, and so forth, horizons into that. And so that's a whole other methodologic part of this package of implementation science that I think needs to be considered. And then finally, there's dissemination science, which after we figure out what is beneficial and what isn't, how do we roll it out everywhere, universally, and what are the barriers to that? And in terms of, say, the NIH, they have an implementation science and dissemination science study section, and the dissemination and having a dissemination plan, from their point of view, is a critical part of an implementation science project that shouldn't be forgotten. So these are all very different from the standard set of tools that were taught and that I teach and that we learn to use as epidemiologists and biostatisticians. One thing Dennis didn't mention in terms of the Pioneer Award is that one of its essential requirements is that the recipients must be proposing an area that's of great interest to the NIH, but that's completely new to the investigator proposing it. So you can't, like say I worked on measurement error and misclassification in statistics for many years. I'm sure I wouldn't be successful getting a Pioneer Award by making it look like it was something totally new. In fact, I didn't even want to mention the word measurement error or misclassification anywhere in the proposal because I had to show that these were all new areas to me that I was going to both be learning about. And then, it's very true when you come in from the outside in an area that you haven't worked on in a long time, you get a lot of ideas that maybe people who are like really embedded in it and are kind of in their track and going along, they might not think about it. And I've really seen that it's worked that way for me, and it's been a lot of fun. So I won't say much more about this except that a number of you who I spoke today are aware that I have a ongoing commentary in the American Journal of Public Health where I'm talking about some of these, where I'm basically developing in greater depth some of the topics that I'm talking about today. And this first one that I'm referring you to actually had to do with these definitions and trying to make a connection to it. And the bottom line for me was that all of these different separate, apparently or possibly apparently different disciplines, from a methodologic point of view, I think there's tremendous overlap. I'm not sure if there's anything that I'm working on that would be useful in impact evaluation that wouldn't be relevant for comparative effectiveness research. So from a methodologic point of view, I wanted to make the point that the work that's being done and the things that I'm discussing in the column would apply no matter which one of these boxes you happen to put yourself in or your particular study. So maybe this is preaching to the converted a little bit, but we want to know how through implementation science in these related areas here, how will we use this knowledge? So in the end, we want to develop an evidence base for cost-effective preventive strategies to achieve domestic and global health. And also another piece of this that's very important is to eliminate both domestic and global health disparities. So I'm going to skip an example that's in here actually, but it's a very, I think, very important and striking example. So I'll just mention it quickly without going through the slides, and that has to do with maternal mortality. So I think people here may know that we had the Millennium Development Goals, and it was either MDG 4 or 5, I can't remember. Its goal was to decrease maternal mortality by, I think, 1/2 by 2015. We did not succeed in that. But what's really very striking about maternal mortality is, A, it's the biggest health disparity in the world. The maternal mortality rates differ, I think, by more than 100-fold between some European countries that have very, very high standards of health care and places in sub-Saharan Africa where healthcare still is under development. And on top of that huge disparity, it is virtually eliminated in high-income countries. We know how to completely prevent, with some very, very rare exceptions, maternal mortality. So it's all about implementation science. How can we get these interventions that prevent maternal mortality among all of us here, but aren't succeeding in doing that in other places? There's no new knowledge about the cure to maternal mortality needed. It's all about, we know how to prevent it. How do we get it to people so that it doesn't happen? Another example here that I've used is diabetes, where a number of interventions in individually randomized trials have shown that diabetes risk can be reduced quite substantially, but yet there's been a failure to roll these out at any higher level, and it's something that I'm very excited to be working on right now. And then the other piece is the cost effectiveness piece. We know that the United States, we're one of the richest countries in the world. It's certainly in the 16 highest income countries, yet we're at the bottom of the 16 highest income countries in terms of major health indicators such as adult male and female lifespans and other things. So implementation science can address these things, especially when we link the health impact assessments to the cost effectiveness assessments. So now I'm going to get into the statistics. Let's see how I'm doing on time. I said I was skipping maternal mortality, so I'm sorry, but I'll have to do that. So the NIH sent me, and maybe some others here, they were looking for study section reviewers for who are competent to evaluate implementation science studies. And they listed, it was very useful, they listed, they had a long list on this slide of all the design strategies that they were looking for people with expertise in. And on the next slide, it's the analysis strategies. So there's all sorts of designs here. I can't really go over them, but what I yellow highlighted were the ones that are the standard part of curriculum in epidemiology and biostatistics programs that I know about. And then you can see there's many other designs that come up in implementation science that aren't part of our standard epidemiology and biostatistics curriculums. And then similarly, they listed their long list of analysis methods. And I orange highlighted the ones that are part of the standard curriculum in biostatistics and epidemiology. And then you can see huge gaps of other types of analysis methods that come up in implementation science that aren't really part of our curriculums. And for me, I mean, I didn't really know about, when I started working in this area just a couple of years ago, I didn't really know what a lot of these things are or how they would be used. And now I've learned quite a bit. I can't even say I know about all of them, but I know about most of them now. And indeed, they numbers of them could be very useful. And even as epidemiologists doing standard epidemiology, some of these might be useful. So Dennis mentioned the Pioneer Award, and the main thing I might want to say about it, other than what's already been said, is that I did convene a stakeholders advisory board because since this was very much new for me, I felt I really wanted to make sure that with the resources and time that I had, that I was choosing the highest impact questions to study and methods to develop. And since wasn't really working in that area, I had previously been working for a large extent in the nurses' health study and the health professionals study, and the kind of methodologic issues that come up there are very different than what comes up in implementation science investigations. I needed that advice, and related to that, why I wanted to even say anything about it right now is that I'm very open to suggestions here from you all as well. If you're encountering methodologic problems in your work, and this work is implementation science, broadly defined in the way that I mentioned earlier, please do get in touch with me and let me know, because we're always looking for the best and most important topics to be working on. So now we can talk about rigor. So it seemed to me that there are three widely held myths that limit implementation research and its translation to policy and programs. So the first one is that evaluations must be randomized. So coming from a background in epidemiology, that wasn't a hard barrier for me to personally overcome, because we feel in epidemiology, not that we get everything right all the time, we are using observational data, but we feel that we've generated an enormous amount of useful knowledge using rigorous observational data analysis techniques. So, but on the other hand, there are other communities of researchers who very strongly believe that if an evaluation isn't randomized, it's useless. So there's two communities that have a tendency to feel that way. So one are people who call themselves trialists, that is, people who are involved in the clinical trials community. And then the other, surprisingly, I found out, are people in the health economics field. So health economists discovered randomization and randomized methods maybe like 5 or 10 years ago, and now they're like, I'm sure there's probably some economists here, and it's come up before, but my impression is now they're called, they have their own conferences where people feel so strongly they're called randomnistas, meaning that they only believe research if it's been randomized. And so, yes, we love randomization. I love randomization when we can do it, but most of the time we can't. And so does that mean that we can only learn about a tiny number of things because we can't randomize everything that's of interest? Or can we use observational data methods to try to get at some of these things in a causal manner? Another one, valid results require individual level data. So in public health practice, and I know this from being part of the technical assistance team to Management and Development for Health, which is the major implementer for HIV treatment and care through PEPFAR in the Dar es Salaam region. I've worked with that group since 2004 until very recently. The data that come in are a combination of individual level, patient level data, and group level data. So I know there's a lot of people here who have done work in other countries where you've probably all seen the register books, those big leather-bound notebooks where people in the health facilities will write down the name of the person, the date, and fill in a small number of fields. And then what's reported to the next highest level is a hand count of, say, how many births were there in the past month, how many people were initiated on ART. It's the group level data. Now, yes, maybe we could go back to the registers and get the individual level data sometimes, but maybe we don't have to get every single individual level data point. Maybe a combination of group level and individual level data will give us essentially all the information we need to answer our questions. And then another big issue, I think, maybe this one is less rigor, but it has to do with maybe the consequentiality of implementation research, is the gap between conducting and running a study or a program evaluation and when public health policymakers have to make decisions. So I've had the experience now of, again, in Dar es Salaam, we had a study called Familia Salama that was funded by the Elton John Foundation and Comic Relief in the UK. And its goal was to look at the relative sort of comparative effectiveness of option A versus option B in PMTCT. But we were like 2/3 through the study, and the World Health Organization basically put out the guidelines, not just of option B, but option B plus. So our entire study was obsolete. We couldn't even get an answer in time, and we're still analyzing the data, I'm sorry to say. And we may find out that option B isn't even any more beneficial than option A in the contexts and settings in which it's conducted. Well, that couldn't even be part of the decision-making process. And there's many examples of this sort of thing. Another one has to do, I have another project I'm working on in Bobani, Swaziland with the Clinton Health Access Initiative, looking at the relative benefits of early access to ART versus following the standard of care guidelines, not just on the patients who newly become eligible, but everybody in the clinic. Well, we were about 3/4 through that study, and early access to ART has already been rolled out universally throughout sub-Saharan Africa. So we're finishing our study, but it is a little discouraging that we're not able to get these answers in time to actually help inform data-driven decision-making. So I'm very interested if other people have experienced this, what thoughts we might have as a community of public health researchers to, pick up the pace so that we can actually provide products of our research in a timely manner for decisions to actually be made using the information. So on the randomization piece, randomization is beautiful because if it's done well, it will we automatically are adjusting on average for confounding. We even lost a follow-up. We can assume on average under pretty mild assumptions They should be balanced between the two groups, and so we shouldn't have to worry about selection bias or dependent censoring. We have no measurement error misclassification of the exposure because we assign it to the patients ourselves or the facilities if it's a group level in the intent to treat perspective. So it gets rid of all of our standard sources of bias in observational research, confounding, selection bias, and information bias. But there have been many new developments, and I know several colleagues today brought up some of the work in causal inference that maybe was initiated. Well, actually, there's even a controversy about that. Since I'm at Harvard, I was about to say was initiated by Jamie Robbins and the Harvard Causal Inference Group, but actually the Stat Department, Don Rubin and his colleagues in various places also played a very major role in that. And then there's the Judea Pearl Group at UCLA, and then the Mark Vanderlaan Group at Berkeley. There have been, and then in economics and even in social science and education, there have been a lot of people actually working on causal inference for observational research. But maybe in epidemiology and biostatistics, it's the work of Jamie Robbins and others that has taken hold most firmly. And its purpose actually is to very explicitly formulate the relationship between an observational study and the randomized trial we wish we could have had, so that we could make the counterfactual inference on average that we would like to make, therefore having causal research. And in the end, a lot of it boils down to what to do about time-dependent confounding, because it turns out that many of our standard methods for controlling for confounding that we've already known work just as well, or have have advantages and disadvantages to some of the newer methods if we're not in the time-dependent confounding area. But we do have some additional ways to control for confounding now, including propensity scores and IPW, reweighting the data to IPW methods. And then, of course, there's the whole set of quasi-experimental methods using instrumental variables that have been introduced and are now part of the toolkit, allowing us to make causal inferences more intentionally and with more rigor. But another area, this is one that I and my group have gotten involved in, is if you studied a little bit on the causal inference, you might know about the SUTFA assumption. It's the standard stable unit treatment assumption, and part of it is that everybody's independent. So that's a problem. Even in a cluster randomized trial, everybody isn't independent. So using the most of the causal inference methods, you could treat your units, say each cluster, each facility or village, as a independent unit, and then apply the causal inference methods. But you lose a lot of power doing that if the intercluster correlation is less than 1. So trying to extend the causal inference methods to allow for correlated data has been a focus of some of the work that we've been doing, and I'll talk about that a little bit more. And then you have the quasi-experimental methods in addition to instrumental variables. There are these designs and analyses methods that have come up in economics that I think are useful to us, namely regression discontinuity, difference in differences, interrupted time series, and I think there's several others. So that big body has to do with here about dealing with confounding. Now, the next piece would have to do with loss to follow-up, or what we might call an epidemiology selection bias. So I would like to call your attention to the work of that Elvin Gang and Dennis and others have done with double sampling for loss to follow-up. So it's a lot of these methods are not an either-or. Either we can't do anything or we have to have the perfect study. So this double sampling approach is, yes, people are being lost to follow-up in most of our studies in resource-limited settings in practical situations. So what can we, if loss to follow-up is jointly associated with both the exposure or intervention and the outcome in a non-multiplicative way, we could have bias in our estimate of the effect. So a way to deal with that would be to go back and resample a subset and find out in the two groups how many people were lost to follow-up, what their mortality rates were, and so forth. And I think that work is very useful. Then another piece is the non-adherence. So in an intent to treat analysis in a randomized trial, non-adherence is, at least in the primary analysis, a non-issue because you know what people were assigned to, and that's the exposure of interest. But in a sort of implementation science setting, we can do intent to treat analysis, but I think we're also interested in how the intervention was delivered, its fidelity, and the impact of the different aspects of the intervention. Well, that's where it turns out that my previous line of research, which has to do with measurement error and misclassification, actually comes in very handy, because non-adherence is essentially, from a sort of mathematical point of view, a type of measurement error. So in the time that remains, I have 15 minutes, or maybe even 20, to I'll talk in a little bit more detail about some of the methods. So what happened with the Pioneer Award is it provided me money, which I then went out and hired 5 postdocs. And then each postdoc is working on a different methodologic area that I identified to be important for further advancing implementation science. So the first postdoc that came in, Ashley Buchanan, who's here, she actually is no longer a postdoc because after receiving a K99 award, she got a faculty position at the University of Rhode Island, and she had to give it up to go on to be a faculty member. But what we were working on and what we're continuing to work on is exactly the issue that I mentioned earlier about estimating network effects in cluster randomized designs. So I'll try to go over this a little bit. When we have a network or cluster randomized design, in many cases, there would be an index participant who actually received the intervention, and then there would be network members who wouldn't directly receive the intervention, but would indirectly receive it through their relationship with the index participant. So there's been some work on these methods in infectious disease and in the design and analysis of vaccine trials, because it's the same sort of thing. If you get enough index participants or you get enough people vaccinated, you develop herd immunity, and everybody benefits, even if they didn't directly get the vaccine. So in our case, the work was motivated by a trial called HPTN 037, which was a study of methods to reduce risky behaviors among intravenous drug users. The risky behaviors included both risks connected to getting HIV, as well as risks related to other sorts of adverse health effects from sharing needles and other sorts of risky behaviors. So the way the study was designed was a certain number of what we call index participants came forward. They were randomized to either get the intervention or not, and then they named other people in their social networks. That was people they either injected drugs with or had sexual relationships with. And each index participant had, I think, between 2 to 5 network members. And so the question is, what's the direct impact of the intervention on these index participants? That's usually where most study designs stop. But actually, because they're in communities and we're talking about social behaviors like needle sharing and sexual relationships, that the intervention could quite easily have an impact on the network members as well. So the first thing, because like we said, we're trying to do this in a very rigorous causal inference way, is to define, from a counterfactual potential outcomes perspective, what are the different quantities of interest. So the first thing I'd like to say is you can see these y's here, minus, or it could be divided by, if we're interested in a ratio measure, times the expected value of outcomes among all participants, index and network members in the control networks. So if let's say, take the most extreme case where you have one index member and you have 100 network members, and there's no effect on the network, there's no dissemination of the effect, you're going to get something that's going to look almost like 0 when you average in this way, because almost everybody has no benefit because they're all the network members, and then you have this effect only in a small fraction of people. It just washes out. And the other thing you can see about this crude or composite measure, it's still a causal measure, but then it's also conditional on the compositions of the network in the studies, and its external generalizability could be compromised, because in one study, maybe there's 100, on average, 100 network members to one index participant, and you see almost nothing. And then in another study, let's say each one only has one network member. Well, the overall effect, or the crude effect, will be about half of the direct effect, and you should see something. So it's like we talk about measures, the external generalizability of different types of measures of effect. If this measure is nice in that it's purely, it's got its advantage. It's a purely randomized measure. And that's nice. And you can do the direct counterfactual causal inference by averaging the observed outcomes in the intervention networks versus the controls. But there's also a lot of information that's potentially lost, as well as the external generalizability. So then we could say, okay, the composite effect, or we might call that the total effect. Well, that's going to compare. It's going to compare the potential outcomes of index participants in intervention networks to control participants or network members in control networks. And this would give you the absolute effect of both from being in the network as well as directly receiving the intervention. And then the problem, though, with these, and I'll tell you what these other two are, but you can probably see it here. This is not randomized. Even if we randomize the networks, this contrast isn't actually, in and of itself, would not be a causal contrast without using some methods to adjust for confounding. We define two further measures. So the disseminated effect is the effect of being in a intervention network versus being in a controlled network without being the index participant directly receiving the intervention. And then the individual effect is the effect of being the index member in a intervention network compared to being a network member in an intervention network. So, and these two will add up to that one. From a causal inference perspective, as I mentioned, the standard estimators of them are potentially confounded because the index participants, and then sort of by definition, as a result, the network members are all volunteers. So index members could be either worse in terms of risky behaviors or better. They're not necessarily representative. And we'd have to, and chances are they aren't, they are different. So then we have to get into methods, causal inference methods to adjust for confounding so that we can make these causal contrasts. Maybe what I'll do is I will show you here the results. This is from the HPTN 037, where we applied these methods. We developed the methods basically using generalized linear models, parameterizing the effects, controlling for confounding, and then taking into account the correlations. And sort of mathematically, it turned out to not be that hard a problem to solve. And I think maybe the real contribution was in conceptualizing the different causal contrasts and potential outcomes of interest. But what we found was sort of what we said, that the crude effect or overall effect was smaller than the total effect, which is down here. So not that much smaller, though. It was definitely a beneficial intervention. And so we saw that the crude effect was like a 60% reduction in risky behaviors overall versus a total, which was, say, 65%. But we were able to also see the disseminated effect was like a 35%. So there was actually a very big benefit from being in a social network of index participants who directly got this intervention to reduce risky behaviors, and then the index participants themselves also had a benefit, which is actually smaller than just being in the intervention network. And that was kind of surprising. In fact, in the earlier slide where we talked about terminology, this kind of what we're now calling disseminated effect used to be called a spillover effect. And you'll see that in the literature. It's the same thing. But the idea there was that, well, maybe network members might get a benefit, but probably not. It might spill over to them. And it was almost sort of a bad thing, or almost a contamination. But actually, you know, looking at these data and thinking about the ideas, you can see how implementation science studies could be designed to both capture the extent of network effects and then come up with cost-effective interventions where you really don't have to deliver it to each individual person, but maybe we can figure out how tight the network has to be. And networks, there's a whole network science area where you can say how network members, that's not even a 0 or 1 variable. It may be just like we have first degree relatives, second degree relatives, and so forth. They have similar ways of describing network members. Well, how maybe do first degree network members get a benefit, but then second degree no? So then we would know the best ways to do this. I have 5 minutes. I'll just tell you maybe very quickly about one other thing we were working on. So I mentioned this issue of individual level data versus group level data, a very common situation. I also mentioned the Familia Salama study, which was looking at the benefits of option A versus B, also crossed with the community health worker intervention to try to improve the number of pregnant women who had the WHO recommended 4 or more antenatal visits. And we had data on over 75,000 pregnancies from registers with a certain amount. It was individual level data, but with only a small number of confounders. And then we had a population survey of around 1,500 women with very detailed confounder data. And using these kinds of 2-stage designs, we could, you can see that we saw, this is applying the methods. The investigator that I was working with, he wanted to he was so worried about the quality of the registry level data, even after we had gone through the trouble of like having a large army of data entry clerks going into the facilities and entering data from 5 different types of registers on over 100,000 pregnancies. The investigator was worried about the quality and he wanted to throw it all away and just report the findings from the population survey of 2,500 people. And I'm like, no, we can't do that. We can't throw away all these data. Let's use both. And that's where these 2-phase designs came in. And actually, you can see that there was a benefit. This is looking at whether the community health worker intervention increased the chances that pregnant women would have 4 or more A and C visits. There was a significant effect, quite good, and it was, you know, with a 0.04 significance, and that could have been what we reported. But when we used the registry data alone, there was a bigger benefit apparent, especially after we controlled for confounding using the 2-stage methods. We get almost a 3-fold, highly significant benefit. So that's just to illustrate the advantages of 2-stage designs in these large-scale public health program evaluation settings. So I need to wrap up. I'll tell you we've also worked on step wedge designs. I'm not going to talk about that. We just submitted a paper on that. We've also worked on calculating incremental cost effectiveness ratios. That gets back to the economic evaluation, but using empirical data to estimate the life years gained from the 2 intervention groups rather than using some of the simpler methods that have been available. So that's another project that we've worked on. We're working on optimal treatment regimens for colorectal cancer screening. We're working on causal mediation analysis and developing inference methods to estimate mediation proportions, which is very important, again, from the point of view of rigor and people doubting the value of information from non-randomized studies. If you show a beneficial effect of an intervention, and you use, you know, rigorous methods to begin with, but then you can also postulate a pathway. Well, if we see, let's say, an improved, a reduced perinatal and neonatal mortality rate based on an intervention. And we can also show that we increase the proportion of women going to ANC, and we increase the proportion of women who had various types of checkups. Then we can show we show the mechanisms that this intervention led to process outcomes that are known to lead to these health outcomes. We've strengthened the overall findings. So I'm a big fan of causal mediation. And maybe I'll just go straight to my conclusion. Implementation science and its related disciplines are new and growing areas of research, ideally situated in schools of public health. I doubt there'd be anybody here who would disagree with that. Epidemiology and biostatistics have much to offer, both in terms of the methods we've developed and the methods that grow out of them, and in terms of the translational projects that stem directly from the existing more etiologic research that epidemiologists have often focused on. There's much to learn, both in terms of methodology as well as substantive findings. And there are many new opportunities for funding support for translational public health research, both methodologic and substantive. And I like to bring this up because many of us always think NIH is the only place. Well, first of all, I showed that the NIH, at least in theory, is very receptive to this type of work. We maybe do feel in practice it could be improved, but there's also a wealth of other funders who are interested in this sort of thing. You know, starting from CDC, PEPFAR, UNAIDS, 3IE. There's a lot of other opportunities that many of us, at least in my world, hadn't really thought of. PCORI, haven't really thought of before. So on this note, I think I will conclude, and I'd be happy to take questions and comments.
I'll start.
Oh, great.
So the network effect of some of these interventions is fascinating methodological.
Oh, maybe even, I might be able to even get this mic going. So, do you guys know how to get it going? No? Oh, it's dead. You can also come up and join me, but that's going to really make everybody not want to say anything. All right, good.
The methods development and looking at outcomes in the networks of people who receive an intervention is fascinating, and I you do see its potential implications for infectious diseases. And I'm thinking about some of the polio vaccine trials where vaccinating, giving people live oral polio vaccine and having them excreted in the community ends up vaccinating indirectly.
Yeah.
But I think it seems like there's also applications and importance of this work in non-communicable.
I totally agree.
Knowledge fusion seems to be one area, but social media pretty much could propagate lots of secondary and direct benefits of interventions. And I just wondered if you thought outside of the infectious disease realm.
Yeah, so it's a great question. I have thought about it. I mentioned to a few people here I'm working on a study called India Works that's rolling out sort of proven interventions for the reduction of risk of diabetes and cardiovascular disease in 8 large work sites in North and South India. And so one novelty is to be doing it in a work site, which is a community in itself, whereas the previous evidence was individual, but we're also trying to change the foods and the price structure of the foods in the canteens to encourage healthy eating and also improve physical activity. And clearly that workers who are at these work sites, not everybody at the very large work sites, so not even everybody at the work sites are going to get the interventions, but it could well spread to other people at the work sites. And then there are the families of the workers. They're both male workers and female workers. As an NIH study, it's easier in this setting where we're working to have more male workers, but they want it to be 50-50, which is great. But in any case, people are going to bring this home and maybe change their cooking patterns at home, change what they're choosing to eat, what they're telling their children to eat. And so we can well see this spreading. Now, of course, our individual study isn't funded to look at those things, but there are people who are hoping to maybe get additional add-on supplements to be able to. But, you know, in the case of interventions, it might even be that it's more likely than not that public health interventions would spread. And maybe we'd be thinking of what intervention would only be restricted to just the individuals who receive it. So I think it just opens up a huge area for us to be both designing studies and conducting research. Yes?
Could you elaborate a bit on how you use a two-stage design to take rich data from a small sample and presumably adjust for confounders in a less rich but very large?
Yes, so it's not that hard actually. What's done is basically you create weights of how the people in the second stage where you have the richer data, what predicts from the first stage who got into the second stage, and it can be by design or by chance. And then you basically use something like an inverse probability weighting to kind of approach to turn the second stage into the first stage you would have seen. And the better your weights are to predict who's in the second stage, the closer you'll get to having the full power of the data if everybody had all the confounders. And that's the basic idea. And that method has been around for quite some time, although it's hardly ever been used. And then what we've added now is to allow this to be used in the context of clustered data so that we can get the right variances when data have this additional, you know, 1 or even 2 levels of clustering. Yes?
In your social network study, are you sure that your intervention group is overlapping with your non-intervention group?
Yes, that's a great question. She's asking about contamination or mixing of networks or clusters. And so, no, we can't be sure. And all the data that I showed you actually comes from Philadelphia. That's where HPTN 037. And I don't know how small or large the communities of intravenous drug users are, but it's quite possible that there's contamination between networks, and that would be yet another level of methodologic research. First of all, we need to get the data, information about the extent that that happens. And there are some other people I know of who are looking at that, but another idea that I find very interesting sort of mathematically is that networks aren't really 0-1 variables. They're distributions in a sense, and it's all the data maybe in a study might have some correlation, and then there's just clusters that are more tightly correlated to others. And maybe that's a way that we need to be thinking about and looking about at this, or maybe methodologically, if we think of it as one network with different amounts of correlation, we might be able to get farther, but it might be a bigger break from what we're already doing, where we're looking at things as discrete clusters, which are what all the analysis methods do. Yes?
I was curious about the cost-effectiveness studies that you were mentioning. I mean, obviously, they've been looking at incremental life, social effects.
Yeah.
And you were saying that new methods.
Yeah.
You went pretty quickly.
I know.
You could detail them a little bit more.
Sure. So far, I mean, our main contribution is, from what I understand, especially in the health economics world, you have to, in order to calculate incremental cost effectiveness, a different measure is used than what we're used to in epidemiology. Mainly, it's life years in the intervention group, predicted life years, and then estimated life years in the control group. And then you subtract those, perhaps weighted by costs in the numerator or the denominator. So how do you get the life years from, let's say, a Cox proportional hazards model, which is designed purely at estimating relative risks? The life years are a function of the underlying baseline incidence rates as well as the relative risk. And so what it seems to be done in health economics is use a sort of standard Weibull probability model, like 2 parameters, which may fit well in certain cases, depending on what those parameters are and what the population is to be generalized to. But actually, we run into situations of like, even if the relative risk is constant across, say, age and other covariate levels, you have what we might call an epidemiology effect modification. The expected life years are different. So then you have to weight that according to some population to which you want to generalize, using ideally, say, modern survival data analysis methods to get the sort of non-parametric survival curve. So those are the sorts of things that we're doing to enhance the estimates and ideally get better estimates. I actually have an example where we use the standard Lidl model to look at the incremental cost effectiveness ratio for second-line ARVs in the greater Dar es Salaam area where I had worked, comparing the standard method to the sort of methods that we're working on now. And it happens in that case, I don't even remember, when you use our method, it's not cost effective. When you use the other, it was. So you really can get very different answers. But that's the idea.
Was it a wide range?
Well, I mean, I can quickly see if I can get to it. I know exactly where it is. Oh, wait. Okay, so what we got was here the incremental cost effectiveness ratio was 4,855 using our method, but now I think I've deleted what it was previously. I think it was much smaller. I'm sorry, I just can't tell you. I'm not prepared today. Yes?
How again are you identifying clusters in these studies? Is it social networks?
Well, I think it really depends on the study. So in the HPTN 037, these index participants named people who they had either shared needles with or had sex with, I think, over the past 3 months. And those were the candidate network members. In another study, like there's a big HIV prevention trial going on in Botswana right now that's randomized villages to the full combination prevention package versus standard of care. And so the clusters are villages. So it really ranges from one context to another.
So I guess you can see how there would be multiple sources for correlation in some of these studies. Maybe in Africa, where the villages are really discrete, the geospatial aspect is, like there's no overlap. But Philadelphia or New York City, if you have social networks, it's where people live, where they go to school and work, yet where the geospatial sources are correlation.
Yeah, no, I know. So that was related to the question earlier that was asked. I think it's like an open area for methodologists. Like there's been very little done to account for, like what we've just done, just account for one level of clustering in causal inference is a somewhat of a, I don't know, breakthrough is probably too extreme, but a new contribution. And then to start looking at these more complex situations where the network is actually a continuum is a whole new area of research that I think could be very interesting and useful. And then also, we have to wonder, well, like I was saying to some people today, so it's not perfect, but if the correlation is a lot higher between the named networks than those outside. So maybe there's a little bit of bias, maybe the variance is a little bit off, but is it a major problem? Like I always do like to do bias analysis first, because sometimes people worry about things that aren't necessarily that important, and then you spend a lot of time and then you do your, to statisticians, the worst thing is we work on a mathematical problem, we solve it, and then we can't find a motivating data example because the method never makes a difference. So we don't want that to happen, and that's something else I'm trying to be careful about. Was there anyone else? I thought I maybe saw anyone else. Okay, sure. Hi.
I'm a student of health policy and management. I wasn't very curious with healthcare utilization. Would it be possible to use any of your methods or some of these upcoming new approaches to better estimate both the costs for some of these chronic conditions, like for diabetes, or like if we were able to just offset the diagnosis of one condition for X number of years, and then how does that affect that lifetime? What are the cost savings? I'm always very curious about that.
Yeah, so I think there's a lot of people doing those sorts of things, and even in terms of the specific thing you mentioned, probably there are some papers that have done it, if you look. But, that gets into a whole other area that I haven't gotten into, but I realized, like, let's say if I was going to write a book on implementation science methods, if you think back of that slide I had in the very beginning of all the different topics, the one that comes up with that in relation to your question is the modeling. Because it's like we can estimate the impact, we can estimate the life years, we can estimate the costs, and then you have to do this modeling to predict the future. And so that's a whole other discipline. I don't know if you guys have people here, but there are people who specialize in modeling, and that's what they do, and there's different types of models. I don't know very much about it. There's like agent-based models, and then SIR models, and I know very little about it. I've just been to a few talks, but my guess is for somebody who was interested in that methodology, there probably are unsolved problems as well.
Well, I want to thank you very much, Donna, for coming.
Yeah, my pleasure.
We in our newly formed institute will be following your work quite closely,
right.
And very happy to have the dialogue. And maybe hope to have you back again some more after you continue to develop some of this work.
Sure, it'd be my pleasure. Thank you all so much.
Thanks very much.